lumbar puncture. Okay. So lumbar puncture with examination of cerebrospinal fluid. So why they do the lumbar puncture means they want to draw some fluid from the spinal cord. That's a CSF, cerebrospinal fluid. Okay. So the cerebrospinal fluid is a liquid. Where it is located? It is located in the central nervous system. The central nervous system parts are brain and spinal cord. These two are protected by the covering layer, that is meninges. In between the meninges three layers, we have the liquid, that is protecting layer with filled by the liquid like matter, that is known as cerebrospinal fluid, brain and spinal both. Okay, so if they want to do any examination of infection in the brain, then they will do this procedure. Like cerebrospinal fluid is an important diagnostic tool for a variety of infections and non-infections neurological conditions. This technique indications, contraindications, and complications of LP, lumbar puncture, in adults will be reviewed here. This technique of LP in children. Okay, so in children and for spinal and other types of neuroaxial anesthesia is discussed separately. Okay, see lumbar puncture in children and spinal anesthesia technique and epidural and the combined spinal epidural and anesthesia techniques. Okay, so these different types of anesthesia they will provide. Analysis of CSF is diagnostic. Okay, so indications urgent, when it is required urgently means the number of definitive indications for LP has been decreased with the advert of are many complications may be there is a separate code for the headache after LP, post procedural headache. In the G89 series it will come. So usually the patient will suffer headaches, that's why they never do this properly. Usually they never do this. Okay, so whenever it is required urgently, patient is having continuous ejaculatory vomiting without any injury, the patient is showing ejaculatory vomiting means the vomit force is very huge when we compare with the normal vomiting. So there is something change in the nervous system. Maybe there is a tumor, maybe there is a severe blood clot inside the brain, then the ejaculatory vomiting will happen. Okay, in that urgent scenarios they will do this procedure. Okay, so and the suspected infections of nervous system, suspected subarachnoid hemorrhages. Okay, CT scans is showing some abnormal hemorrhage in the subarachnoid area. Immediately they will do this procedure. Okay, the most common use of the LP is to diagnose or exclude meningitis in patients presenting with some combination. Cases where the doctor can do LP. Okay. So conditions in which the LP rarely diagnostic but still useful include multiple sclerosis, Guillain-Barré syndrome, and paraneoplastic syndromes, and neurosarcoidosis, CNS vasculitis. Okay, so LP is also required as a therapeutic spinal anesthesia and intrathecal administration of chemotherapy. Okay, so an intrathecal administration of antibiotics. If they want to introduce some medicine intrathecally, then they will go for this procedures. Puncture they will do, they will place one catheter there to pass the medicine. Okay, contraindications possibly post procedural pain may be there, post procedural headache may be there, thrombocytopenia, scars maybe happens on the epidural, so that scar maybe get infected, will get abscess of spinal cord like that. So multiple post operative complications are more. Okay, so post LP So lumbar puncture is a procedure of taking fluid from the spine in the lower back through a hollow needle, usually done for diagnostic. Usually they will do this procedure in between L2 and L3. Why? Because the spinal cord ends at above the L2 and meninges can continue below the L2. So if they are puncturing in between L2 and L3, there is no chance of damage of spinal cord. They can draw the fluid, only CSF can draw. Okay, there is no matter of touch of spinal cord. So there is no danger. That's why this is usually they will select in between L2 and L3. The LP will happen. Lumbar puncture will happen. Okay, so if it is a diagnostic or therapeutic, we have to check for that. And without imaging guidance, 62270. With imaging guidance, maybe it is a fluoroscopy or CT, 328. Okay, or ultrasound, 62270 and 7694 to both we have to report. If it is a MRI, 62270 and 77021. For MRI and ultrasound, we don't have any combination codes. We have to report separately. And if it is a therapeutic without imaging guidance, 62272. And with imaging guidance, same fluoroscopy or CT or ultrasound or MRI. Ultrasound and MRI, we have to report 70,000 series separately. Is only the classification of codes here for lumbar puncture. First of all, we have to check for that whether it is a diagnostic or therapeutic. Okay, and now CSF shunt, cerebrospinal fluid shunt. In the medical terminology, we have two terms like looks like stent and shunt. Stent is a intraluminal device. Okay, internally in the blood vessel, the doctor has to place the device to dilate the blood vessel in the case of stenosis. Okay, but shunt is not an intraluminal device or extraluminal device. It is a catheter pipe, plastic pipe. It is okay. Whenever the patient is suffering from hydrocephalus, most accumulation of fluid in the CSF increasingly produced by the ventricles of brain. Okay, then the doctor has to draw excess fluid to decrease the pressure on the brain. Okay, so he will place one catheter from the ventricle to peritoneal cavity. Through the peritoneal cavity, they will enter into the kidney, kidney to blood system to kidney, kidney to filtering, and the patient can pass out via urination. So excessive CSF will be okay removed in this way. Okay, so that's why it is known as VP shunt, ventriculoperitoneal. Ventricle means empty places in the brain is also known as ventricle. It is not a heart ventricle here, it is a brain ventricle. Okay, ventricles are nothing but empty places in the brain is also known as ventricle. So that is a starting point, that is a proximal. Distal will be tip end will be in the peritoneal cavity. Okay, so ventriculoperitoneal shunt. These two in between proximal and distal, there is a, regulatory system is there, that is valve. So we can control that. If you want, you can stop. The pressure is normal, you can stop with the valve. Okay, so controller may be there. So that is proximal, distal, and controller. Three things are there. Okay. This is a cerebrospinal fluid, VP shunt. So proximal is belongs to ventricle. Okay, this is distal, maybe into the chest area, thoracic pleural cavity area, or peritoneal area. So this is known as VP shunt. Okay, distal and proximal. So cerebrospinal fluid setup, VP shunt setup, maybe it's having three components. One is proximal, one is valve, and distal. Three are there. These three combinedly known as one complete procedure to remove the excessive CSF from the brain. Okay. These are the procedures. It's a shunt system, it's intracranial or spinal. You have to check for where exactly it is placed. Okay. It's a creation, procedure, reprogramming intracranially. It's a proximal catheter location, distal catheter location, subarachnoid or subdural or ventricular. Distal may be atrial jugular or auricular or peritoneal or in a pleural and other terminus like a VP shunt. Okay. And if it is any procedure, it's not creation, procedure, already existing VP shunt, procedure the doctor is planning. Proximal is doing the procedure on existing VP shunt, on the proximal or on the distal or only on the valve or any above two combinations as done. Okay, that you have to check. And type of procedure may be irrigation, revision, removal, or replacement. Okay, irrigation is ventricular catheter irrigation cleaning. Okay, any obstruction that will be cleaned by the doctor here. And types of procedures: revision, removal, and replacement. Okay, if it is a replacement, partial replacement or complete replacement, you have to check. And spinal creation, removal, and replacement or irrigation via laminectomy or via percutaneous, we have to check. Is a placement of shunt. Okay, it is very regular procedure like neurostimulators in the SDS of nervous system. Lumbar puncture is rare. It's an office procedure. But we should learn, we should know that. Sometimes they can ask any questions regarding that. But VP shunt is completely procedure on SDS. So within 24 hours, the patient can discharge. Okay. It is a shunt system, intracranial or spinal with the codes. Creation, what are the codes? See here, these 3 points are there below. Okay. So report 62230 and 62225 for replacement of only the valve and ventricular catheter. Report 62230 and 62225 replacement of only the ventricular and distal catheter. Okay. Report 62258 for replacement of complete shunt system. So complete shunt system is replaced, then we have to report 62258. Okay, and try this example.
Six two two 70942.
Why? Because it is a ultrasound guidance, right? To detect the spinal imaging, so ultrasound guidance also we have it outside. Okay. 7694 62328. Why? Because it is a therapeutic. The patient is coming for headache. Okay, so headache treatment they are giving that not for the diagnostic purpose. They are not sending to the laboratory. If they send to the laboratory, then you will code it as a diagnostic. But they are not sending to the laboratory. They are just puncturing and drawing the fluid. Okay, for headache. So it is a therapeutic. So 62328. So don't get confused in the selection of diagnostic or therapeutic. This is important. This one related to VP shunt.
Mother 6.
What is the code?
62230 62225.
Two codes we have to give as per the guidelines. 62225 and 62230. These two codes. Okay. So while we are teaching there, I have given the 3 points, right? As per that 3 points, here it is a combination. Two things they are doing: proximal catheter and valve. Both are done. That's why we had to put 2. Okay. This is the conclusion. You can take a pick. So if anyone is asking in the interviews, you can reveal all these things. Okay. And next topic we have here, skull base surgery. Okay, it is an inpatient procedure, but we should have some idea. So these are the skull base parts. So maxilla. So is it cranium or skull? Whatever you are seeing in the picture, is it cranium or skull? What is that? Without mandible, it is cranium. With the mandible, it is skull. So there is no mandible you are seeing here. That's why it is a cranium. You can say it as a cranium. If mandible is also there, then you can say it as a skull. Okay, so all these are the eminences and parts. So if there is any surgery done below the cranium, okay, in this view they are seeing this. This is a view how you are seeing here. The upper row of the teeth, okay, below the behind the teeth, palate. Okay, so nasal conchace. Okay, so this is foramen for spinal cord. So all these are, okay, so comes under inferior view of cranium. Okay, so gross anatomy: frontal bone, ethmoidal bone, sphenoid, temporals, okay, occipital, okay, parietal bones. All these are cranial bones. So we have these bones are separated from each other by sutures. Say different types of sutures are there. These kind of terms you can get into the medical record. Okay, so you should know that. So sutures are like this. So it is not there. See here. In between these two bones, there is a connection like zigzag method. These are known as sutures. Okay, zigzag method. The bones are connecting with each other in the skull or in the cranium. Okay, so anterior cranial fossa, middle cranial fossa, and posterior cranial fossa are these three are the regions where we have in this part. Based on the location, we have separate codes. The procedure is performed in the anterior cranial fossa and middle cranial fossa and posterior cranial fossa. Based on the location, we have separate codes. Additionally, a poorly defined region termed the central base of the skull is often used clinically to denote the region, okay, centered on the pituitary fossa. Okay, so central is very typical. Central base is typical, but anterior, middle, and posterior, where the procedure is happened, that you have to check. That is the first step. Okay, so anterior approach is different. Okay, definitive approach procedure repair or reconstruction, what exactly the doctor has done. Why? Because for approach only we have separate code. We should report separate code. It's difficult to reach up to there. Okay, so approach procedure and definitive procedure and repair or reconstruction procedures. It's a three different kinds of procedures the doctor can perform in the skull base. Okay, see, surgery of skull base mostly based on the approach procedure, definitive procedure, and repair or reconstruction. What type of procedure has to happen? So approach is anterior cranial fossa and middle cranial fossa and posterior cranial fossa. Where exactly is reaching? Okay, and see, anterior cranial fossa location procedure, definitive procedure is performed in the anterior, so you should be checked thoroughly. Approach also should be in the anterior. Okay, you are reporting approach code up to the anterior and location code is middle. It's not matching. So approach and procedure, both locations should match. That is only the thing what we have to check here. Okay, and level extradural, intradural. He's crossing the dura mater. Without opening the dura mater, he's doing the procedure like extradural. And primary closure, mid-face flap or forehead flap, he is using that flap to close that procedure site or surgical site. Free skin flap, based on the type of flap, we have separate codes for primary closure. If it is a secondary closure, by free graft or by local or regionalized flap. Okay, so primary closure at the time of procedure only, same episode of care. And secondary closure next day or any after another day of the surgery. That is secondary closure. Okay, so repair and reconstruction, how he's performing, that we have to report separately. And definitive procedure, what he has done, that we have to report separately. And where he is approaching, that we have to report separately. Total 3 codes will come. Okay. And do not report modifier 62 with 2 surgeons is not applicable here for skull base codes. Okay, so this is a basic guideline. Of course, 2 doctors or 3 doctors are involving. They will pay only one payment. It's a huge amount. Okay, for this procedure, they are paying large amount. That's why 2 surgeons are not allowed here. Okay, do not report 62 modifier. If you want, you can go with the AS modifier. For technicians, 80 modifier for surgeons as assistant. Okay, but 62 is not allowed. When coding for skull-based surgeries, the approach and definitive procedure code must match the anatomical location. That's what I said. Approach is anterior and procedure should not be in the middle or posterior. Okay, approach and definitive procedure both should be in the same location. You have to check for that. And when one surgeon performs the approach procedure, another surgeon performs the definitive procedure, and another surgeon performs a repair and reconstruction, each surgeon reports only the code for specific procedure performed without any 62 modifier. Okay, 3 procedures done by 3 different doctors. You can report 3 different procedures, CPT codes without any 62 modifier. Okay, report with 51 modifier if one surgeon performs more than one procedure. One surgeon only performing 2 procedures. And second procedure will be reported with the 51 modifier. Okay, if 2 different surgeons, no modifiers at all. Individually, you can report. That is a base guideline here. Do not report secondary reconstruction codes with approach or definitive procedure. Why? Because it is another day. Secondary reconstruction will be done on another day of the surgery. That's why we should not report any approach code and definitive procedure on the same day. Okay, so it is another day, so you have to report separately. And read once again these 5 guidelines and let me know if you have any confusion still. Clear?
Clear model.
Yeah. These are the coding concepts with the codes. Okay. Anterior cranial fossa. Maybe it is a craniofacial or orbitocranial or bicoronal. Okay. 61584 and 61586 and 61585. Like this, we have to report for these two. For craniofacial, extradural or intradural. Intradural only one code is there. Extradural without maxillectomy, maxilla bone, they are not cutting. Okay. Osteotomy of base of anterior cranial fossa, orbital accentration, the same terminology the doctor has to use in the documentation. Okay. And middle cranial fossa, it's infra temporal bone. Okay. So including parotid glands also, they are removing. Parotid glands means it is related to salivary glands. Okay. And orbitocranial zygomatic bone is there, right? So this belongs to mid cranial fossa. And posterior cranial fossa, transtemporal, transcochlear through the ear, transcondylar or okay, uh, petrosal is a muscle. Petrosal is a ligament. It is okay. So how he is approaching inside this? That is approach procedure. Based on the location, we have separate codes here. So this is definitive procedures, what the doctor can do. Second procedure. Okay, it's a definitive procedures in the anterior, middle, and posterior again. And repair and reconstruction, primary closure and secondary closure. Primary closure, all the integumentary system, 15,000 series for the flaps. So if it is a secondary closure, 60,000 series we have. Primary closure, 15,000 series will come. Secondary closure, 60,000 series will come. Okay. So again, same procedures and location. Procedure. First one is location. Second one is procedure. Okay. So try this one. If you want, I will go back to the tables.
61580 with 62.
62 is not allowed here. I said right, 62 is not allowed. Okay. 61580 is enough. They are asking only for Dr. Bailey service, not for Dr. Al procedure. Dr. Bailey, what has done, they are asking for that. That's it. So do not report modifier 62. This one.
So 61592.
597. Okay. Same doctor has done two procedures. Middle cranial fossa across the womb. Okay, so temporal bone is doing the procedure there, zygomatic approach. So here we have two codes we have to report with 51 modifier. Check what is the 61606 and 61597 clearly in the book.
Uh,
Okay. And this is a conclusion. These things we have to remove base information. So you people are requested some charts with answers, right? So I'm sharing with answers by tomorrow morning. So we will I will be available after lunch on Saturday. Post lunch I will be available entire day. Okay. So whenever you are free, you can connect for the discussions of the charts also on the Saturday. Post lunch I will be available for you people.
Yes.
Okay. Any other doubts you have? So preparations for the interviews, whatever it is you have, any concern, we can discuss on the day. The entire Saturday after lunch, I will be there available for you people. Okay.
రెగ్యులర్ క్లాసెస్ వైజ్ అయితే ఈ రోజే లాస్ట్ అన్నది.
Huh.
ఓకే.
So what do you think about Unislink? So discuss with the Shravan.
నో మదర్, నాట్ యెట్
Okay.
డిస్కస్ చేయను.
Okay. Okay, so we'll meet on Saturday, so at your convenient time.